what is the basis of our choice of this consensus grading system? So what decisions did we take? The first, we used a two-tiered grading system, low grade and high grade. And the reason for that are, one, the lack of prognostic value of intermediate grade, especially when necrosis is excluded. Simply the fact that two-tiered grading system is more simple than a three-tiered grading system. As I showed in the beginning of this presentation, the rarity of medullary carcinoma in meeting very high mitotic and Ki67 cutoffs that I used in a three-tiered grading system, like in the gastrointestinal neuroendocrine system. Now, why did we use 5 and not 3 mitoses, for example, or 2 mitoses? Well, the reason is because the cutoff of 3 mitosis or 2 mitoses captured too many tumor as high grade. We thought that was not really reasonable. So that's why we used the 5 mitosis cutoff. Now, why did we add Ki67? I have to be honest, I was not so much keen about it. I didn't think that it has that many added value, but I was convinced by other colleagues because you can use Ki67 as a check for mitosis. Because as Dr. Rivai will tell you, who is, by the way, an expert in counting mitosis when he was a fellow here, there is a significant amount of inter-observer variability in identifying mitosis between pathologists. Also, in some instances, the fixation, the way the specimen is handled can really diminish artifactually the number of mitosis. And finally, we accepted that because it's more in sync with what other pathologists are doing in other neuroendocrine tumors, like the GI, where they use Ki67. So kind of political pressure here, but there is a push, and we saw it in the World Health Organization meeting in the upcoming WHO fascicle on endocrine tumors, that for a universal grading system for all neuroendocrine tumors, or at least to use the same building block parameters.